You ever get that feeling that you're talking to yourself? No. And we're not talking about that today. Welcome to Gut Part 3. On the left-hand side of the slide, I have the two most common causes, risk factors for pancreatitis. The first one is definitely a global phenomenon, and that is alcohol. The second one is biliary disease. And to understand that one, you have to remember that the gallbladder itself sits just underneath the liver, and then the biliary tree descends from the gallbladder and the liver down to meet the pancreatic duct and then exit into the duodenum at the sphincter of Oddi. Patients who have biliary stones can have them lodge at the distal aspect of the biliary tree, blocking the pancreatic duct and causing obstructive pancreatitis. Now, there's an important clinical word that I want you to attach to pancreatitis, and that is autodigestion. Remember that the majority of the pancreas is exocrine in nature, so it has to get pancreatic digestive enzymes out into our gut. There's all kinds of them. The main ones we're focused on are amylase, which digest carbohydrates, and lipase, which digest fats. Well, guess what? An inflamed pancreas cannot move those digestive enzymes out. Therefore, they remain in the pancreas. And when you happen to have enzymes that are supposed to break down foods trapped in your pancreas, hence the term autodigestion. The pancreas basically starts getting eaten by the enzymes it produces. Really bad versions of pancreatitis can have autodigestive phenomena occur all over the body, whereby digestive enzymes get leaked into circulation, go throughout the whole body, and wreak havoc. Autodigestion within the abdominal cavity can cause bleeding, and ecchymosis can be the result. Cullen's sign is an indication of abdominal autodigestion characterized by ecchymosis around the umbilicus. Gray-Turner's sign is another sign of more systemic autodigestive occurrences, and these are ecchymoses going down the flank. Thankfully, most cases of pancreatitis are limited to the pancreas, and they tend to be acutely painful. So you ER nurses are going to see these patients coming through the ER doors going, "Oh, it hurts so bad." Hey, autodigestion, not a cozy thing. But they'll be hurting, they'll have this intense pain, probably nausea, probably vomiting. They may or may not have noticed stool changes. And the stool changes are from the lack of the enzyme lipase, which breaks down fats, from getting into the gut. Without fat breakdown, the fat moves right through, and the result is something called steatorrhea, or fatty stool. It also tends to be quite foul smelling. In patients with pancreatitis, you probably could have guessed that measuring and following over time the blood level of amylase and lipase is a common way to trend this condition out. Just like you'd follow troponins in a patient that had heart injury, just like you'd follow liver enzymes in a patient who had liver injury, so too will you follow amylase and lipase levels in patients who have pancreatic injury in the form of pancreatitis. Sometimes more workup needs to be done than that, and in that case, there's all kinds of imaging that can be done. One of them I want to highlight, just to add into your clinical testing vocabulary, is the ERCP test, endoscopic retrograde cholangiopancreatography. And if you're wondering why people refer to it simply by ERCP, that's the reason. Think of an ERCP as kind of a more glorified version of an endoscopy. Instead of just kind of going down looking at the esophagus and the stomach, they're going lower and lower and lower, all the way into the duodenum to look right at the sphincter of Oddi, and there's little instruments that can actually look inside and sometimes break up stones that have lodged right in there or not. It's pretty cool. You can take pictures, you get direct visualization of the pancreatic duct, endoscopic retrograde cholangiopancreatography. Yeah, ERCP. A lot of us have heard of pancreatic cancer, and a lot of us have heard that it's not a great diagnosis. I'm here to confirm that if that's your understanding. Unfortunately, the clinical presentation of pancreatic cancer is such that it does not produce outward symptoms until the mass has gotten substantially large and potentially spread to other organs, even prior to diagnosis. I listed here the two most common genetic alterations, one to an oncogene called KRAS, Kirsten Rat Sarcoma gene. Horrible name, but geneticists have a horrible sense of humor. KRAS is an oncogene, and in roughly 90% of pancreatic cancers, this particular oncogene kind of behaves just like ALK-EML4 in lung adenocarcinoma. It's constitutively activated. It's always sending its grow and divide signal down into the nucleus to transcribe the appropriate proteins to get that job done. But where would a mutant oncogene be without the loss of a good guy, a tumor suppressor gene? And in the vast majority of pancreatic cancers, our old buddy, the guardian of the genome, P53, is knocked out. Cholelithiasis, bile stone process, the process of forming bile stone. Cholecystitis, bile sac inflammation. One can lead to the other, but
I like big butts and I cannot lie.
Cholelithiasis is not the only cause of cholecystitis. It's just the most common. So stones develop from kind of the normal constituents that make up bile. They just kind of create this hard precipitate. Stones can be asymptomatic. Some people are not outwardly demonstrative of stones when they have them. But if there's a lot of them in the gallbladder, or if some stones get out of the gallbladder and lodge in the biliary tree, then you can have obstructive problems. Once obstruction occurs, that's where things start to inflame, and you go from a cholelithiasis clinical picture to a cholecystitis clinical picture, or cholangiitis, which is inflammation of the bile duct, or maybe both. The classic clinical presentation is right upper quadrant pain and radiating pain to the right scapular area. I want you to think about that for a minute, because a lot of the pathologies of the lower abdomen, because of the poor innervation down there, radiating pain is one of the primary features that you need to know to ask for as a nurse. This pain oftentimes gets really bad shortly after a meal, especially a high-fat meal. The clinical presentation itself oftentimes includes vomiting There could be stool changes as well. This is something that I want you as a nurse to remember to ask patients that come in with a clinical picture that looks like it could be a gallbladder issue. If they are not getting bile into the gut, bile is one of the major color components for stool. So remember to ask your patients if they have noticed color changes to their stool. Without bile there, stool color doesn't have that usual brown to it. It actually starts to fade. And some patients will say, it looks like a pale yellowish type of color. Some people describe it as kind of more of a grayish tone to it. I usually tell students, ask if patients have noticed discoloration to their stool. And you can go one step further, because let's say hypothetically that a biliary stone gets all the way down and is just blocking the actual opening to the duodenum. In that setting, not only is it blocking bile from getting out, but it's blocking amylase and lipase. You can have a patient with cholecystitis, pancreatitis, and they're not getting any enzymes into the gut at all. You could have steatorrhea coupled by discolored stool. When there is an obstructive process and the gallbladder is inflamed, the liver, which is right upstream from the gallbladder, can suffer. So in these patients, you may see liver function tests drawn as well, and pancreatic enzymes if there's any worry that the pancreatic duct is blocked. Irritable bowel syndrome. Basic pathology. Question mark. I don't have much to say here. There's a lot of theories going on. There's nothing definitive in terms of pathology for patients with irritable bowel syndrome. What we know is people complain of cramping, diarrhea, constipation, all kinds of bowel irregularities. This is a major lifestyle diagnosis. Some people will map out bathrooms on the way to a destination. But what we don't have is a clear understanding of what exactly is going on. So contrast irritable bowel syndrome with appendicitis, where we know exactly what's going on. Itis is inflammation. Appendi is the appendix. We have inflammation of the appendix. Most common cause of inflammation of the appendix is an obstructive process. The term fecalith refers to a piece of stool that is hardened and was just the perfect size to kind of get in there to where the appendix was, obstruct it, and cause an inflammatory cascade. As that obstructive process is occurring, the appendix can't empty. It starts to engorge. This kind of positive inflammatory cycle is going on. The appendix gets more and more distended. The patient feels more and more pain. There may be necrosis going on. And the interesting thing about appendicitis is its clinical scenario. So first of all, this typically occurs in younger individuals. And the classic clinical picture is somebody whose pain from the obstructed appendix starts as a very vague pain. And remember, our abdominal viscera are not usually all that well innervated with sensory nerves or nociceptive nerves, such that a lot of times we can't feel exactly what's going on when it comes to the abdominal organs. So patients get this kind of vague umbilical pain. What's going on? It's kind of achy. And then over time, as the appendix is getting bigger, more distended, it starts to do something. It starts to push on the right lower quadrant of the abdomen. Now, if you push on your abdomen, you can probably feel that pretty well. The same thing can happen from the inside. So over the course of a day or so, what was periumbilical pain actually migrates down to a point called McBurney's Point. Here we go with more people hanging their names all over everything. But yeah, McBurney's Point, that area kind of 2/3 of the way between the umbilicus and the iliac crest, whereby appendiceal pain is characteristic. In assessment class, you're going to talk about the obturator sign and the psoas sign. I'll briefly just tell you that both of these leg manipulations are done to intentionally irritate or elicit pain in a patient with appendicitis. If these two signs are negative, does that guarantee your patient doesn't have appendicitis? No. If these two signs are positive, does that guarantee your patient does have appendicitis? No. All these clinical assessment tools do is raise or lower your suspicion for what might be going on. I'll also mention before we finish talking about appendicitis that it is important for people to get to a hospital and have the appendix removed prior to it rupturing. And the reason why is this. If an appendix ruptures, we now have an area where the flora, the microbiota of the gut, can enter into a sterile abdominal cavity. This is basically the exact same clinical picture that we talked about with peptic ulcer disease and perforations. If the appendix ruptures, the patient now has much bigger problems than just a distended appendix. And this is a scenario for nurses that's almost a little bit counterintuitive, because rupture of the appendix is oftentimes associated with a marked reduction in pain. That pressure valve has been released and patients all of a sudden feel better, when in reality, they're worse. They're way worse. So appendicitis needs to be intervened upon quickly while the pain is still going to avoid appendiceal rupture. Inflammatory bowel disease, ulcerative colitis, and Crohn's disease. Both of them are autoimmune phenomenon, but they behave slightly differently. And that's the take home to understanding why these two diseases are technically different. Ulcerative colitis tends to keep its inflammation at the distal colon, and it would flare up, and exacerbations of ulcerative colitis would stay at the distal colon. Crohn's disease, by contrast, tends to skip around. Not only the colon, but in some patients, they can have Crohn's inflammatory exacerbations of the small intestine and the stomach. I had a patient years ago who had Crohn's exacerbations in her stomach and duodenum, and she lost the ability to make intrinsic factor, and therefore lost the ability to absorb B12. She had to be on B12 shots because of pernicious anemia, a B12 deficit-related anemia that can lead to megaloblasts, or very large erythrocytes. In terms of clinical presentation, abdominal pain, abdominal cramping, diarrhea, and changes to the stool. The changes to the stool can be either gross blood, frank red blood in the stool, and that clinical term is hematochezia. I always want to laugh when I say that word. Why am I a 12-year-old? I'm a 12-year-old. I can't even say hematochezia without laughing. Or melena. And melena is a black tarry appearance to the stool that indicates blood has been in the gut long enough to break down, release its iron, and mix with the stool, giving it a black tarry look to it. Diagnostic workup is basically the same for both of them. Stick an endoscope up their colon, see what's going on. But the complications can be a point of distinction. Remember I said ulcerative colitis tends to stay in the same spot. If a patient has exacerbation of ulcerative colitis, remission, exacerbation, remission, exacerbation, remission. Every time there's an exacerbation, that's an inflammatory process in the same spot. Anytime there's inflammation occurring long term in the same spot, that potentially leads to cancer. Ulcerative colitis patients are at risk for colon cancer. Because Crohn's disease skips around, it also gives tissue a break from inflammation. So while Crohn's disease patients aren't at as high a risk for colon cancer, one of the interesting complications of Crohn's disease is fistula formation. And a fistula is an open communication, a hole, if you will, connecting one organ to another.